Hello guys, I'm Dr. Ravindra Savarkar and I welcome you back to Mid School. You must be aware that number of COVID-19 cases are again rising in many parts of India. In view of recent spikes in cases, COVID-19 National Task Force has released revised guidelines for treatment of COVID-19 in adult patients. We are going to go through these guidelines in this video. There are three categories of COVID-19. In mild disease, there are symptoms of upper respiratory tract infection with or without fever, without shortness of breath or hypoxia. In moderate disease, either respiratory rate between 24 to 30 per minute with breathlessness or SpO2 level between 90 to 93% on room air should be present. In severe disease, either respiratory rate more than 30 per minute with breathlessness or SpO2 level less than 90% on room air should be present. Patients with mild disease are advised for home isolation, where they should follow physical distancing, indoor mask use, and strict hand hygiene. They are treated symptomatically with hydration, antipyretics for fever, and antitussive for cough, etc. Patient should stay in contact with treating physician. Patient should monitor temperature and oxygen saturation at home. Patient with mild disease should be hospitalized if patient develops difficulty in breathing or SpO2 level less than 93%. Or patient is having high grade fever or severe cough, particularly lasting for more than 5 days, or patient belongs to high risk category. High risk category includes age more than 60 years, patient with cardiovascular disease and coronary artery disease, diabetes mellitus, immunocompromised states such as HIV, leukemia, or ongoing chemotherapy, etc. Active tuberculosis, chronic lung, kidney, or liver disease, cerebrovascular disease, obesity, and unvaccinated persons. There are some oral drugs which were used widely in treatment of COVID-19, but depending on recent evidences, they are not recommended anymore. This includes hydroxychloroquine, ivermectin, azithromycin, doxycycline, lopinavir-ritonavir combination, molnupiravir, and favipiravir. In mild disease, antibiotics should not be used unless there is clinical suspicion of bacterial infection. Possibility of co-infection of other endemic infection with COVID-19 must be considered. Systemic corticosteroids are not indicated in mild disease. As we have already discussed, moderate disease is when respiratory rate is between 24 to 30 per minute with breathlessness, or SpO2 level is between 90 to 93%. Such patients should be admitted in wards. Target SpO2 level is 94 to 96%. In COPD and other chronic lung diseases, target SpO2 is between 88 to 92%. Preferred device for oxygenation is non-rebreathing face mask. This device has mask which fits over nasooral area, O2 line, reservoir bag, expiratory valve and inspiratory valve. Oxygen go to reservoir bag from O2 line. During inspiration, oxygen flows through inspiratory valve into mask and inhale into lungs. There is no flow through expiratory valve during inspiration. During expiration, air does not flow through inspiratory valve but exhale out through expiratory valve. Due to this mechanism, exhaled air is not mixed with oxygen in reservoir bag, which remains filled with pure oxygen. This is how non-rebreathing face mask ensures the most efficient use of oxygen. Awake proning is encouraged in all patients requiring supplemental oxygen therapy. Position is changed sequentially every 2 hours. Steroids are indicated in patients requiring oxygen supplementation. Commonly used steroids are dexamethasone 6 mg per day or methylprednisolone 32 mg per day in 4 divided doses. Steroids are usually used for 5 to 10 days or until discharge, whichever is earlier. Patient may be initiated or switched to oral route if stable or improving. Steroids are not used in patients not requiring oxygen supplementation and after discharge. Risk associated with steroid is secondary infections such as invasive mucormycosis when used at higher doses or for longer than required. Anticoagulation is used to prevent clot formation associated with COVID-19. Approved anticoagulants are unfractionated heparin and low molecular weight heparin. They are used in weight-based prophylactic doses. For example, enoxaparin 0.5 mg per kg per day subcutaneously. There should be no contraindication or high risk for bleeding for use of anticoagulants. Monitoring is very important in admitted patients. In clinical monitoring, respiratory rate, pulse and blood pressure for hemodynamic instability, and change in oxygen requirement are given close attention. For radiological monitoring, serial chest X-ray and high-resolution CT test are done only if there is clinical worsening. For lab monitoring, CRP, D-dimer, and blood sugar are repeated every 48 to 72 hours, while complete blood count, kidney function test, liver function test are repeated every 24 to 48 hours. Patients with severe disease are admitted in ICU or HDU. In severe disease, symptomatic treatment, use of steroid, use of anticoagulants, and monitoring is same as that of moderate disease. In patient with severe disease with incremental O2 requirement, work of breathing, which can be judged by breathing pattern, decides further line of management. If work of breathing is low, indicated by quiet breathing, then patient can be managed with non-invasive ventilation, applied with face mask or helmet, whichever is available. If work of breathing is high, indicated by labored breathing, then patient should be managed with invasive mechanical ventilation. If NIV is not tolerated, then IMV is used. Use of high flow nasal cannula can also be considered. In supportive care in moderate and severe cases, euvolemia is maintained with IV fluids. Dynamic measures for assessing fluid responsiveness are used if available. Cases of sepsis and septic shock are managed as per existing protocol and local antibiogram. Neutralizing monoclonal antibody and convalescent plasma should not be used. Remdesivir was used widely in COVID-19, but according to recent recommendation, remdesivir is not indicated in each and every patient. It is given 200 mg IV on day 1 followed by 100 mg IV OD for next 4 days. There is no evidence of benefit for treatment more than 5 days. It should be started within 10 days of onset of symptoms. Remdesivir should be given to patient having moderate to severe disease with high risk of progression requiring supplemental oxygen. Remdesivir should not be given to patient not on oxygen support at home setting and to patient on invasive mechanical ventilation or ECMO. Relative contraindication for remdesivir are estimated GFR less than 30 ml per minute per meter square of body surface area, or AST and ALT level more than 5 times the upper normal limit. Tocilizumab is IL-6 receptor blocker used to circumvent cytokine storm associated with COVID-19. It is given 4 to 6 mg per kg in 100 ml NS over 1 hour. It should be given preferably within 24 to 48 hours of onset of severe disease or ICU admission. It should be given if following conditions are met: rapidly progressing COVID-19, not responding adequately to steroid, and needing oxygen supplementation or invasive mechanical ventilation, preferably to be given with steroids. Significantly raised inflammatory markers like CRP or IL-6. Infections like active TB, fungal and systemic bacterial infections are ruled out. Long-term follow-up for secondary infections such as reactivation of TB, flaring of herpes is ensured. Thank you for watching this video till the end. If you have any query or suggestions, please write it down in the comment section. If you like my work, please like this video and share it with your friends. And to get notified about next video upload, please subscribe to this channel and hit the bell icon. Till next video, take care and keep learning.